Hi everyone, my name is Jason Ortman. I'm the ALS Education Specialist for Regions Hospital. I was a former captain paramedic on St. Paul Fire. We're making this recording for you. Your administration approached us and asked us to do some bleeding control, not just self-care and buddy care, but also civilian care. And in addition, they asked us to do a quick review of nasal Narcan use. So it's going to be a very quick ride. We're going to run through nasal Narcan first, and then we'll talk about bleeding control and some best practices. As I said, this is going to be a very quick review of intranasal use of Narcan, and along those lines we're also going to review some terms: opiates, opioids, overdose, as well as a quick review on how to actually administer the Narcan. The media, of course, has kind of grabbed onto opioid and opiate and used them kind of back and forth interchangeably. And not to really mince words, but an opiate is specifically a naturally occurring substance derived from opium, and that's what we're talking about, heroin. But when we talk about opioids, that's when we synthetically manufacture medication very similar chemically and working on the same receptor sites within the body. As I said, opioid has kind of become the overall overreaching term to describe anything that is opiate and opioid related. And it isn't really that important that you keep opiate and opioid straight. The bigger thing is realizing and understanding that opiates and opioids are the only things that Narcan is going to work on. When we look back, if you'd had a surgical procedure 25, 30 years ago, they weren't the best at managing pain. The pendulum had really swung, it was really in this area of almost grin and bear it. But partly because of medicine and studies that showed that if we didn't manage a patient's pain, they had worse outcomes, we also found that the pharmaceutical companies had a bit of a part in this, and they really were pushing things like oxy. And so the pendulum swung to trying to absolutely erase pain. And patients would take their pain medication as prescribed after surgery, and at the end of it, they'd be dependent. I can personally vouch for this. I had, during my time on St. Paul, had 2 back surgeries, and I took my oxy and Valium and everything that I was supposed to. And by the end of the course of treatment, I ended up going through withdrawals. Shakes, sweats, nausea, the whole bit. Well, if you're to the point where your body's physically dependent on something, you're a breath away from addiction, and all it would take is just the right set of circumstances and stresses to get you to become an addict. Obviously, with overuse and addiction and dependence, even appropriate use of these medications has found that it caused drowsiness, dizziness. You know, all the oxy and oxycodones have don't operate machinery, don't drive a vehicle. Well, along those lines, they also cause respiratory depression. And that's one of the biggest problem side effects for us. And the fact that if somebody overdoses, it's going to severely inhibit their respirations. Even if they don't overdose. Maybe some of you have had a surgical procedure or an outpatient procedure, and during the recovery period, the nurse kind of prompts you to, hey, I need you to take a breath. That's because you're still drowsy, your respiratory drive is still down. And when we get to an overdose, then we have severe respiratory depression. And unfortunately, some of these are intentional, some are unintentional. There's not really any control we have over that. But obviously, if we impact respirations and drive them down, in turn, heart rate drops. And if respirations stop, heart rate stops. So that's where we really want to take immediate action. Many of you have already used nasal Narcan, some with good effect, some without good effect. The good effect was an opiate or an opioid. The bad effect was either a tremendous amount of opiate and opioid, or more likely, the drugs that they took were cut with something else. For a while, Tranq was on the street. Tranq was a drug that was cut with xylazine. Xylazine is a pet tranquilizer. It's not approved for human use. So the reversal agent isn't approved for human use. You just have to wait for that to work out of the system. So people were giving Narcan, 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 not getting a result. And it wasn't because of an opiate or an opioid, it was because of this other drug that was on board. When we have those patients that are pale, sweaty, they look like a corpse, they're breathing literally 3 to 4 times a minute like a fish out of water, those are the ones we definitely want to use Narcan on. But some of you have been on overdoses that were breathing effectively. They had good skin color. They were just unresponsive to efforts to rouse them. Those we don't necessarily have to hit with Narcan. If you're comfortable and they have good respirations, you can roll them on their side. It's a recovery position. It keeps their tongue off the back of the airway. If they have secretions or if they vomit, it holds the tongue off the back of their airway so they can breathe effectively. So you can also monitor them. If their breathing gets worse, you can flop them on their back and go ahead and administer the Narcan. Now this is a kind of a technical slide, and it's all about the pharmacodynamics, how the drug works. And in very simple terms, Narcan goes into the body, it bumps the opiate or opioid off that receptor site, and then takes its place. It takes its place for 30 minutes. After that 30-minute period, the Narcan dissipates, and now the opiate or opioid can resume its place back in there, in that receptor site. And that's the big problem, is if we totally reverse patients and they don't go to the hospital because they refuse, if they're not placed on hold and they don't get medical care, then they're going to very likely rebound. One of the efforts to try and combat these rebound episodes is St. Paul Fire is going to begin leaving what they're calling a leave behind kit. It's a Department of Health grant, and it will have 3 microdoses of Narcan that bystanders, friends, loved ones can administer should their loved one suffer another episode of unresponsiveness. If we make the decision to use, bear in mind it takes 2 to 3 minutes after you administer the Narcan before it's going to actually get through the nasal mucus, into the circulation, and into the receptor sites. And as I already said, it's only going to last 30 minutes once it's in. When we use it, one thing I would really caution, I like this slide and the fact that it very easily shows how to hold it, but keep your thumb away from that little plunger. You don't need to prime it, you don't need to press it. If you press it or prime it, you're going to express the Narcan, and now that nasal Narcan cartridge is useless. What you're going to do is you want them laying on their back. You're going to tilt their head back slightly like you were opening their airway to begin CPR. You're going to place that spout into their nose until your fingers touch the outside of their nostril, and then you're going to depress the plunger. After you depress that plunger, roll them in the recovery position. Remember, one of the side effects, and I didn't mention it because I want to mention it now, was nausea and vomiting. And often the nausea and vomiting is when we're taking those medications on an empty stomach, or more likely, a lot of people who have overdosed have a tendency to vomit when they're reversed. And if they're on their side, their airway's protected, that won't go into their lungs. Remember, it'll take 2 to 3 minutes to take action. The biggest thing, whether you think they have good respirations, you don't think they have good respirations, you're not sure. If you're ever in doubt, give it. If they're unresponsive, you don't know why, you see some drug paraphernalia, give it. You're not going to cause harm by giving it to someone that doesn't need it. You could cause some obviously great benefit to giving it to someone who does. If you have questions about Narcan use, you can funnel them to your training division. They can reach out to us at Regions, and we can get those questions answered for you. Let's get to the meat of this. This is what we were really approached for. And initially we were going to do this class for you in the early spring so that for the summer months where there tends to be more violent activities, that you would have these bleeding control methods in place. So we're going to review bleeding control. We're going to talk a little bit about scope so we understand it. I mean, we understand the importance, but I got a couple of really good pictures that illustrate it. We're also going to talk about bleeding control, where it was for some of you in the past and where I was trained initially to where it is now, because it's a very different beast now. And then we'll review best practices, and I'll illustrate some best practices with some up-close video stuff. This is not a secret. We have to control hemorrhage. In trauma resuscitation, we lack the ability pre-hospitally to administer red blood cells. Once we have the ability to administer red blood cells or a synthetic blood substitute that can carry oxygen, we're kind of at a standstill. So we have to be absolutely spot on with our bleeding control efforts so we can keep as much blood in the body as possible. Now, some of you might be aware, there's a few cities in the United States that have started some preclinical trials where paramedics are administering blood early on scene at trauma victims. The numbers look very good, but there's a lot of logistics behind it. You have to have cooling units and freezers for the blood. You have to have rewarming units for the blood. You have to have an administration unit for the blood. Additional training. And as if supply chain issues haven't been a headache for all of us, blood has always been a very finite resource, and we're usually at a shortage for it. So it is potentially the future, but it's a few years away yet. This is one of the first pictures, and as you'll see, this tourniquet is very low, and we're going to talk about that when we talk about best practices with tourniquets. But what I really want to draw your attention to on this is the size of that clot of blood that is held in the pair of jeans. Now, obviously, this is body cam footage. This officer placed the tourniquet and then was cutting away the pant leg. And the big caution is going to be, we don't ever want to drag our tourniquet through this big clot of blood. It can really stick in the Velcro and can inhibit the function of our tourniquets. But this is a significant amount of blood loss. Jeans will hold a lot of blood. And not only that, to get that big a clot, that's a significant blood loss. We need to stop that blood loss. And that isn't all of it. You can see the smears in the bathroom. There was a significant amount of blood lost before intervention was made. What's going to really illustrate the importance of wound packing is this set of 3 pictures. This is a security camera outside a convenience store. The 2 individuals in the camera had an altercation with a gunman. The person in the foreground, wearing jeans and what looks to be like a rugby shirt, was shot way low in the femoral artery just after that junction. So an area we can't get a tourniquet on. This is the first frame, and you can see the timestamp on it is 1 minute 40 seconds. The gunman left the scene literally 1:37. The shot occurred at 1:35. So 5 seconds prior to this frame, this person was shot. Here we see no evidence of a gunshot. Of course, they're wearing jeans that'll hold a lot of blood. 2 seconds later, this is what we see. We see a significant amount of blood loss. So the pants or the jeans are saturated at this point, and now we're freely flowing blood. Here's 2 seconds after that. More than double the amount of blood externally on the ground. This person's losing consciousness. Same timestamp, 1:44. We have 3 distinct spills of blood. This person isn't deceased yet, but they died. No one knew how to pack a junctional wound, and this person bled out. So that's the importance of this bleeding control. It has to happen. It has to happen early if we're going to have impact. Now, one of the things that's kind of changed our understanding of bleeding control, unfortunately, is trauma understanding comes from wartime. And Afghanistan and Iraq really illustrated some things we knew, but really propelled our understanding. One of the things we're all combating is an adrenaline response. That fight or flight response does a lot of things. It pulls blood from your skin into your core to your big muscles so you can fight. It makes it so that you can tolerate a lot of things you wouldn't typically tolerate. You'll probably injure yourself and not realize you've injured yourself because it decreases your threshold, well, actually increases your threshold of pain and increases your resistance to pain. It also increases clotting. A perfect example, many of you have been either working on an engine on a car or a boat or doing a home remodeling project, working with a tool. The tool breaks free and you lace it into your hand. And you cut the heck out of your hand and immediately break into a sweat. Of course, you clamp your hand because you don't want to see what you did. You call yourself several choice names because you feel absolutely stupid that you did it. And then you summon up the nerve to finally take a look. And oh, well, that's not that bad. Heck, it's not even really bleeding. So you go back to the task that you were working on. And about 10 minutes later, all of a sudden you look down and it looks like somebody's been slaughtering livestock. The wound is bleeding freely. the adrenaline washes out of your system in about 10 minutes in most people, depending on metabolism and everything. Once the adrenaline washes away, those blood vessels open up and they start pouring blood. In Afghanistan and Iraq, what we saw was medics would treat someone who was injured, have their bleeding controlled, put a space blanket on and say, hey, hang tight, I got 3 or 4 other people I got to check on. I'll be back in a few minutes. They'd come back and their party was unresponsive. They pulled the blanket away and they were bleeding out. The bleeding was controlled mostly because of adrenaline, not because of their bleeding control efforts. So it's really something we have to reassess bleeding control, and that's going to be a recurrent message in this. So I already mentioned that we had the old school that many of us learned, and it was rigid. It was very rigid. It was direct pressure on the wound. If direct pressure didn't work, elevation above the level of the heart. If direct pressure and elevation didn't work, you could use a pressure point. And all the EMS textbooks talk about 2, the brachial artery in the arm, the femoral artery in the groin. That's a great disservice to pressure points, which we will talk about. If I did direct pressure, elevation, and a pressure point, and I couldn't control the bleed, then and only then I could put a tourniquet on. And we would usually put them as low as possible. The reason being, the thought was that if we put a tourniquet on, they're going to amputate the limb, and we wanted to save as much limb as possible for the prosthetic afterwards. I think that belief came about because once you did direct pressure elevation or pressure point and you couldn't control a bleed, those wounds were so catastrophic that there was nothing they could save. So they, of course, nipped off the remnants of the stump, made it clean so it could receive a prosthetic. Because at the same time that that belief was in place, if you went into the hospital and had an open knee procedure where they were replacing your knee, you're conservatively talking a 4 to 4.5 hour surgery. There's a tourniquet on your leg the whole time your knee is open. And you would leave the hospital with your leg and a new knee. Afghanistan and Iraq turned all of that on its head. And we finally learned that bleeding control isn't a rigid process. Bleeding control is a spectrum. If direct pressure will accomplish the task and it's a safe scene, do direct pressure. But if it's not a safe scene, maybe it's just going to be having the patient put pressure on their wound, or maybe just slapping a tourniquet on very fast so that you can get the bleeding stopped and protect yourself and protect that buddy, protect that patient, or protect yourself. If it's a junctional injury, we can't put a tourniquet on it, direct pressure doesn't work very well, we need to pack that wound before we put direct pressure on it. If there's 13 patients, I don't have time to do direct pressure, I'll put a tourniquet on and go to the next patient because it's all about speed when we have mass casualty incidents. So it really depends on what kind of tools you have available, what kind of medical supplies you have, how many rescuers you have, how many patients you have, and the nature of your scene. When we talk about direct pressure is very good, it's very effective, it's kind of like everybody's immediate go-to while you're kind of assembling supplies or rescuers. Direct pressure is more effective than improvised pressure dressings. And what I mean by an improvised pressure dressing is when we open up a roll of gauze, many of us learned in classes that if we had an injury, we would put a gauze pad perhaps on the injury, and then as we were putting our roller bandage on that injury, to improvise and get pressure as we came across the top of that injury, we would do a turn. And you can kind of see that it already has a dimple in my flesh, so I am getting more pressure. You can see kind of a dimple in my pants. It is getting more pressure, but that improvised pressure dressing doesn't get us the same kind of pressure as a manufactured pressure dressing. When I'm talking about a manufactured pressure dressing, I'm really talking about things like this. You can see on the left is the Israeli bandage. It's probably the most well-known of the pressure dressings. On the right is the Thin H, and that's a newer version. The Israeli bandage, as you can see, comes packed in a very tight vacuum sealed pack. And I like to try, and if I can, open these fairly cautiously, and I'll talk about why after I get this out. Because the idea is, I'm kind of a minimalist for one thing. I don't carry a ton of supplies in my car. I carry a few Israeli bandages, a few tourniquets, a roll of duct tape, some roller bandage, some bigger gauze pads, and that's really about it. I don't carry a ton of equipment, but I want to try and keep this intact, and I'll mention why it can be in an airtight occlusive dressing for a chest injury. We're going to talk about chest seals at the very end of this presentation. So we take the Israeli bandage, we're going to take this bulky dressing, we're going to place that on the leg, and that stitch just easily breaks away. I'm going to come through this cleat, and when I come through this cleat, that's when I'm going to bear down, and you can see and you can hear how much pressure, and you can see how much pressure I'm getting. We continue, and the stitch just continues to break as we're going along. This elastic I'm going to keep a lot of pressure on because I want to get a ton of pressure on this injury. And you can see it's very easy to use, and the nice thing is at the end of it, I don't have to have any tape or anything. I take this barbed clip and I put it right into the elastic, and it's on and it's tight. You can see how how tight it is on my leg, even at a distance through the camera. As I said, this is an older bandage. They are the initial go-to. They're meant to stay on, so they don't necessarily always pop off easy, which is good. We don't want them popping off willy-nilly. The thin H, on the other hand, as you can see by its design, is an H. So the idea is I bring that roller bandage through the cleat and I pull downward pressure. I bring it around and I bring it through the other upright of the H, and then I can keep going back and forth through those two upright sides, the vertical parts of that H, and get tourniquet-like pressure with the dressing. It's a very good dressing. Here's a good picture of a tourniquet. Again, it's not placed perfectly, it's kind of low. And the big thing about tourniquet use is that we really want to talk about, we always here at Regions talk about putting them high and tight as possible. We always want to be on the upper part of the leg, the upper part of the arm, and all the way up in the armpit, all the way up in the groin. The reason being, earlier I mentioned that the blood vessels would constrict when there's adrenaline released. Well, if the blood vessels are severed, they not only will constrict, they'll retract. And if let's say I had an injury where I lost my leg right at the knee, and I put this tourniquet on really low at the knee, but the blood vessels retracted beyond the knee, I might stop the external blood loss. But the external blood loss isn't all of it. And that vessel is just going to fill that femoral cavity up, and all of a sudden the leg is going to be ballooning up. So we go as high and tight as possible. The other thing, it kind of depends on if you can't stop the bleeding with a single tourniquet, then you place a second tourniquet. Typically, when I had these on my body for use, because I carried two in my EMS pants and two in my turnout gear when I was on the fire department. And that was as a result of, there was a fire in upstate New York. Gentleman lit a house on fire, and then he waited to ambush the responders. The first fire engine arrived first. They got on scene. He killed 2 firefighters, seriously injured 2. And I was the captain of the crew at the time, and shortly after that, there was the Philando Castile incident, and it just, the citizens and their views of public safety in general had changed. And I much would rather have spent the money on 4 tourniquets and never used them than suffer an injury to one of my crew that I couldn't treat or to myself that I couldn't treat. So for self-use, they talk about looping it. So you would go ahead and put it just through this first buckle and then just put a little tab down. The reason we want it in a loop is, like, if I have to place this on my dominant arm with my non-dominant hand, I gotta make it as easy for my left hand as I can. And we always leave them looped for self-application because we're not gonna be dragging them through the blood clot. It's probably gonna be a better view for you if I put it on my thigh So that will be the place, and I'll place this. And you can see I'm going to get it as high as I can in the groin. And I want to almost rock this. I want it super tight. And you can see how tight it is. So the whole idea is that when I turn this windlass, I only have to do 2 or 3 turns and I can feel it right there. It hurts. When you get a true arterial tourniquet on, it's compressing the blood vessel. This is going to hurt. The leg is going to hurt because it's not getting oxygen anymore. And on a thigh especially, because there's so much meat, you may very well have to put a second tourniquet. So you would just go about 1 inch below that first one, place your second tourniquet. I'm going to take this off because it's unpleasant. If you put it on yourself, or you put it on a partner or a civilian, until the medics get there and can manage the patient's pain, you're going to have to talk them down, get them to do some deep breathing, because it really does hurt to leave that on. And the longer it's on, the more uncomfortable it's going to get. This is a really gross picture, but this illustrates a time that there's not a lot of decision making. You're going to jump to a tourniquet. You can't pack these wounds. You can't do direct pressure. Pressure point's not going to be sufficient either. This is an injury from an auger, and then when I mention that, you can see the spiral slices. So it really is, we're jumping to a tourniquet. I already mentioned mass casualty incidents. We don't have time. Time is of the essence there. Maybe it's an open fracture and the bone end is sticking out. We really want to stay away from direct pressure on that, because if we do direct pressure on that, that bone end is like a scalpel. It'll cut through your medical glove, cut through your skin easily. If it's got an open fracture that's pouring blood, get a tourniquet on it. It really depends on what you're dealing with. There's multiple injuries to the same limb. Get a tourniquet on it. I already mentioned this. Don't be afraid to update dispatch. Tell the medics, hey, we got a tourniquet on, we're going to need some pain management from the medics. Or let them know as soon as they get there, hey, we got a tourniquet on and it's causing this guy a lot of discomfort. They'll get that person some pain meds. This is pressure points, and I love this. This is out of Combat Lifesaver. And honestly, if you can feel a pulse on the human body, that's a potential pressure point. Oftentimes in the middle of the night, old people get up, go to the restroom. It's just one of those things that happens to us as we all get older. And the older we get, the less able we are to maintain our blood pressure, especially if we get up quick. So they'll get up in the middle of the night, teeter-totter, fall over, and slice the side of their head open. Head injuries bleed significantly. Not necessarily life-threatening, but definitely produce a lot of blood, and they're very dramatic. If it's a side laceration, one finger on the temporal artery can stop that bleeding. If you get someone who gets slashed at the jawline with a box cutter or any kind of blade, you can do direct pressure on a pressure point on a single carotid artery with great effect. And that can be the difference between that person bleeding out and surviving the event. So don't be limited to brachial and femoral. That's really, it really bothers me. So now we're to wound packing. With wound packing, there's a couple of general procedures that you will kind of see. I'm going to kind of roll this one up initially because I want to demonstrate a couple of things with the regular gauze before I pull a new one and show you a trick that'll make you look like a wizard on the scene. Every tactical person that I've watched and taken classes from talks about making a stone. And what they'll do is they'll gather up a few inches of the material and make a wad of material. What I generally like to do is just take it and tie it into an overhand knot. It accomplishes the same thing. I get a nice little wad of material that I can pack against the wound. But almost everybody reflexively goes to the outside of the roll. And if I do that and I let go of this roll on the scene, that's exactly what's going to happen. It's going to unroll and it's going to go on whatever is on that scene. You've been in the same houses that I've been in. There's feces from dogs, from cats, from cockroaches, from mice, from rats. People, I mean, come on. We don't really need to pack their wound full of feces. Now, Regions, one of the trauma resuscitation things is they're going to get a bunch of antibiotics, but we really don't need to be packing their wound with filthy material. So what I'm going to show you, as I said, is going to make you look like a wizard on the scene. You take your roll of gauze, you're going to grab the very center of it, and you're just going to pull until the very center pops loose. And as you can see, I kind of have a little wad of material already. I don't have to tie a knot. If I really want to have a nice little stone, I can take this, depending on obviously the size of the wound that we're going to be packing, and I can have a nice stone. And the friction holds this in place. It won't go anywhere. It'll continue to feed from the center. And you can put it on their chest, you can put it on their belly while you're packing the wound, and it's just going to feed from that point, so it's not going to get contaminated with everything. Then the idea is I'm going to take my fingers, I'm going to reach into their wound, and I'm going to feel where the blood is coursing from. And when I feel the blood coursing, if I do, I'm parking that stone in that spot. So if I were to use my leg kind of oddly, like I'm packing a wound here, we'll say it was a junctional wound, but I want this crack. So one of the methods is to park my fingers there, keep pressure on it, and then feed this material underneath those fingers. And then to feed more material underneath those fingers. I keep feeding underneath those fingers and keep them in place so that I can get as much pressure on it as possible. Once I can't pack any more into that void, I'm going to reach around my fingers and feel if there's more void spaces that I can pack with material. I want it packed as tight as possible. Then I'll put pressure on it from the outside. Now, the other method, rather than keeping my fingers in place, is kind of the finger over finger method. So I would take a chunk of material, pack it into the wound, take this finger and grab a chunk of material, pack it into the wound, take this finger, pack it into the wound, so that I'm constantly packing a new chunk into the wound. You still keep pressure on it, it works pretty well, but I'm personally biased. I really like keeping pressure against that area where I felt the blood coursing from. It's not like I've done this a ton of times. I've packed 2 wounds in my career, but it's a highly effective method for controlling bleeding. Now, there are some other things out there for wound packing rather than regular gauze. This is something that now is available in the civilian market. The military designed this. It's called the XStat. That syringe is full of basically diced up tampon. You put it into the wound, you depress the plunger, those diced up pieces of tampon go into the wound, and as you can see, they expand. And they put pressure on the inside of the injury as well as our pressure from the outside. And it works quite well. Some of you have also heard of the hemostatic agents. They help with the clotting process. The Tactical Combat Casualty Care Group condones the use of 3: combat gauze, Celox gauze, and Kita gauze. All 3 are very good. However, that same Tactical Combat Casualty Group says that regular gauze, if you pack the wound appropriately, works just as well as the hemostatic agents do. Where we get a little bit of benefit with the hemostatic agents is the military packs all over the body. In the civilian world, we only talk about packing from the belt line down and the collarbones up. We don't pack in the chest and the belly. The reason being, we're minutes, well, especially here from a trauma center. We don't want people spending a ton of time on scene trying to get to a bleed that they're probably not going to get to. But when you think about the military's purpose and where their injuries are, they could be in country and they have to get them packaged as much as possible to exfiltrate them to a site, to exfiltrate them to an airport, to exfiltrate them to definitive care. So they want to pack those wounds wherever they are. And when we're packing something and we can't get it packed quite as tightly, that's where the hemostatic agents have a little bit of an edge, because they do have some material that helps with clotting. The one caution I would give any of you, if you're going to supplement the IFAC kits that were purchased for you, that combat gauze, is that specifically the Kita gauze. It has shellfish protein in its proprietary blend that stops bleeding. And so if someone has an allergy to shellfish, you could very likely cause them some significant harm. One of the last things we're going to talk about is penetrating chest injuries. Now, with a penetrating chest injury, obviously having a collapsed lung isn't a good thing, but it's not the worst thing about it. For one thing, anytime we perforate the chest, we inhibit the body's ability to breathe. The chest has to be intact for us to breathe adequately. The diaphragm drops down, makes this space bigger, that's negative pressure. To equalize, the air just is drawn in. We don't have a choice. And then the diaphragm relaxes, the space gets smaller, it makes positive pressure, the air goes out. We don't have a choice. Now we can choose to take breaths, but mostly it's automatic. So if we think about somebody who's had a traumatic injury and their body metabolism is jacked up and we need to maximize their ability to carry oxygen, we really don't want their chest structure inhibited. So one of the biggest things we want to do is restore the structure of the chest. And it isn't because of the collapsed lung so much, it's because air is getting outside the lung, building pressure and shifting everything over. And you can see that midline on the slide. That blue blood vessel on the top and bottom of the slide is the inferior and superior vena cava. The inferior vena cava, down below, is bringing the blood from about the lowest part of your ribs all the way down to my feet, is bringing all that blood back to the heart. If those organs shift over and that vessel is compressed, which it is easily compressed because it's under pretty low pressure, blood pressure drops. If blood pressure drops, patients don't have good outcomes. So we really want to restore the structure of the chest as quickly as we can. That's where the chest seals come in. The two that are pictured here, one is the halo, and the other is the high fin. They both come in either dual packs or single packs. I like the dual pack because oftentimes, especially if it's a gun that's involved, there's entrance and exit wounds. The nice thing about these is if I tear one of these open, if I tear it cautiously enough, I can split this, and in essence I have created 1, 2, I have the actual manufactured airtight dressing that would be number 3, and I have the backing from the dressing that would be number 4. These, I could actually make 4 occlusive airtight dressings with 1 occlusive dressing. All I need is some tape. Now the inside of this, as you can see, has 3 vents. These little vents are supposed to release pressure so that if it's built up in the chest, it'll evacuate. Many of you remember in class, we would put an improvised occlusive dressing on and only tape on 3 sides so one side could vent. The Tactical Combat Casualty Group, International Trauma Life Support, Pre-Hospital Trauma Life Support have all abandoned that tape on 3 sides. They're now saying tape it on 4 sides, get a good airtight seal. Don't worry about making a vent, because for one thing, the vents typically don't work. Blood usually sticks to the dressing and it sticks to the vent area and it won't allow it to actually vent. Now there's a dressing that comes folded up in the middle of this. This serves one of 2 purposes. One, you can wipe blood away before you stick the sticky dressing down, or if there's not a significant amount of bleeding, you can put this over a smaller puncture wound and put the dressing over the top. That way this is also absorbing blood and you have the airtight seal all the way around. They're very good dressings, but they're expensive. And to be honest, you don't necessarily need that. Many of you, the IFACs that were purchased for you, the little trauma kits that were purchased for you, because they're too bulky, you keep them in the squad. So if you're on the scene and you need to perform self-care, buddy care, or care to a civilian, look around you, see what's available. I mean, it's not fancy, but if you've got medical gloves on and there's only 1 wound, this will work. 1 gloved hand on the wound until the medics can get on scene is an occlusive dressing. If there's an entrance and exit, 2 gloved hands on yourself, on a partner, on a civilian will provide that. If there's a magazine, tear the cover off, rip it in half. You've got 2 occlusive dressings. A Ziploc baggie. It doesn't make a difference. At one of the classes I was talking with one officer who got a life-saving award. He used a t-shirt that was on scene, and it was so full of blood that the blood acted as that airtight seal. The fluid created the airtight seal, and it made the difference for that patient. So it doesn't have to be a high-dollar manufactured chest seal. We want to get the structure of the chest reestablished. When the medics get there, they'll stick big needles in to evacuate the pressure, take the pressure off of that blood vessel. It won't reinflate the lung. They're still going to have to go to the hospital. They still need to get a chest tube in. That's how the lung is going to get reinflated, is from getting a chest tube. I already mentioned once, this was going to come up again. If you have bleeding control, reassess it, reassess it, reassess it. Remember that adrenaline response. If you put a tourniquet on, don't forget it. Take a look, make sure the bleeding's controlled. And especially if we're using things like the Israeli bandage, if that bleeds through, that big pad has to bleed through, and that elastic dressing has to bleed through, or bandage material has to bleed through, that's another like half a liter of blood, and we can't afford those kinds of blood losses. So we have to be pretty vigilant. We have to make sure that our bleeding is actually controlled if we think it's controlled. If you have questions, again, please do not hesitate to funnel them to our training, to your training division, who in turn will get a hold of us here at Regions. I hope that you don't have to use many of these skills, but if you do, whether it's yourself, your partner, the civilian, or your family, you'll have some very definitive life-saving measures that you can take. Thank you for all you do. I would encourage you, if you have the opportunity, to practice. Now, bear in mind that you don't want to practice with a tourniquet that you're going to use. So if possible, talk with your training division, see if they can get a little stash, or if they already have a stash of tourniquets, that you can practice some self-application and buddy application. Again, thank you. Have a great day.